Hi everyone, thanks for having me. So yeah, I'm Pete Frost, police officer in the Met. I've been a police officer now for 17 and a bit years, about 18 years, sorry. Time flies when you're having fun, eh? Yeah, done all the fun stuff, riot police, firearms, all that kind of stuff over a pretty decent career. Been researching suicide prevention within the Met in my own time for about 5 years. But as of October last year, the Met created a specific role, and I was lucky enough to be a successful applicant to come on and do this full time. So I'm the suicide prevention officer. I'm the only one for the Met. Despite the volume, which is something we'll go into a little bit later on. I always sort of open with these ground rules. I appreciate most people on here will be well versed in sort of suicide prevention webinars and chats and talking about research and things like that. But we should never forget that we should look out for yourself and each other. If anything becomes overwhelming, please stick a message in the chat. We can get you some help and all that kind of stuff. And if you're worried about someone else who's listening who may be affected, please sort of reach out to them. If during the Q's and A's or whatever you want to share experiences, please just make sure they're kept anonymous. Like Barney said, it is being recorded as well, so we just have to keep that privacy, not only sort of legally but just in fairness, isn't it, to the family and things. I won't share details of specific cases. I'm also well aware of talking about specific methods, specific locations and things like that. So if I give a bit of a woolly answer, it's just because I am a little bit guarded that don't want to inadvertently cause any suicides by, revealing certain methods, certain locations and things like that. This is a safe space, and most people sort of wonder what that means, but if you're worried about terminology and language, please don't be. I would much rather you ask me a question in whatever terminology, language you understand it, rather than trying to, worry about whether we should use this term or that term, or, whether somebody might find this not so good. In terminology such as people often use things like commit suicide. I know we don't like that terminology, but if the only way to get your question across to me is to use terminology like that, then please feel free, okay? And like I say, at the end, ask as many questions as you like. Otherwise, it's sort of an hour of listening to me, and I'm probably one of the most boring people you'll meet in real life. Okay. So, the police role at the scene of a death. Just before this, it's worth noting, and maybe a theme through all of this that may come of it as a surprise to some people, the number one priority for the police, as it has always been decreed by the first commissioners of the Met back in, I think it was like 1839 or something, is to save life. That is our number one priority as the police. Most people associate the police with solving crime, reducing crime, locking up bad guys, girls. But in actual fact, our number one focus is on saving life. And that is our number one priority. We're positively obliged to act, provided it's not too dangerous for us as well. So, if we're walking down the street and we see somebody collapse, we have to act. I know most of you would act, but you're not under any obligation to, whereas we are as the police. We have to do it, okay? And that's the kind of a theme that you'll see running through this when we get involved in suicide investigations and why we attend sudden deaths as well. So the police role at the scene of a death. So the Met attends, between 7,500 to 9,000, what we in the police call sudden death. So it is a death of a person outside of a care setting where that death was unexpected or unexplained. So that can be homicide, as in a murder. It can be a heart attack where the person wasn't expected to die. It could be natural causes of any other kind, overdoses, vehicle accidents, a whole range of things, but also includes suicide. That number, 7,500 to 9,000, is an average for sort of a non-COVID year. I don't have the figures for the COVID year, I'm afraid, but I think we would all agree that it's significantly higher than that. So when we land at the scene of a sudden death, our first job is to determine whether or not a crime has happened. Is this a murder or is it an unexplained death by some other means. We then act as investigator on behalf of Her Majesty's Coroner, and that's we secure the scene, we give details of medical conditions, of medication that someone's taking, so that the coroner can decide how this person died, and can list that officially. And again, the thing that will run through all of this, and most of you will know, with regards to suicide prevention, the coroner has the final say legally on whether or not something is classified as a suicide. So when I'm talking about some of the data stuff later on, just bear in mind that everything is going to be pre-coronial inquest as well. Sometimes we are called into hospitals and acute care settings for the simple reason of locating the next of kin. So we have access to Interpol, to embassies, to police liaison services all across the world. So if somebody is admitted to hospital and there's no next of kin, and sadly that person dies, then we'll be called in to literally just try and locate next of kin on behalf of the coroner's office. And that's kind of our job. So it can be very difficult when we land at the scene of a sudden death. We are either dealing with a family who are distraught because maybe loved one's been murdered, and we've got to balance that out with securing crime scenes and evidence and everything else that goes with that, arresting suspects. We may land and it could be natural causes, and obviously you're then dealing with a distraught family, or we can land and it's been a suspected suicide, and then we're again to have to manage the scene, gather evidence for the coroner, and put together all of those kinds of reports. So when we talk about a suspected suicide, some people call it an apparent suicide within policing as well. How do we define it? So again, I'm talking about everything pre-coronial inquest in there. So anything pre-coronial inquest, you'll often hear me just use the term suspected suicide. So if we're ever in any kind of email chain or anything like that, it's almost into my spell check. I use that term so often, suspected suicide, because I'm talking about everything pre-coronial inquest. Because like I say, the coroner has the final say legally on whether or not it's going to be a suicide. So the dictionary definition, an intention to end one's life, kill themselves. Sorry, I spoke life right now, haven't I? Which can actually be very, very difficult to classify. So when you're a police officer and you land at someone's death, how can you tell that intent? Intent is one of the hardest things to prove in criminal law, never mind when we're talking about suicidal occurrences. So that can actually be very difficult. So we look at other evidence, we look to other definitions. So within the Met, we use a three-stage process. So we're going to go with dictionary definition. That might be obvious because of, say, for example, certain methods that they've used. It's quite obvious this person, or they've left a note, it's quite obvious this person intended to kill themselves. We would then kind of use a modified version of the Office of National Statistics, ONS definition, and they define it as all deaths from intentional self-harm for persons aged 10 or over, deaths caused by injury or poisoning where the intent was undetermined for those aged 15 or over. Now, we remove the ages. So we basically, all deaths from intentional self-harm for any person, and basically where the intent belies that they intended to kill themselves. Okay, so I know that can cause a bit of friction, but when we're looking at suicide prevention, we shouldn't have the cutoff at 10 years old, in my view. So there will be specialist services that are needed. Think of bereavement support services that would be needed for that age group. Bereaved families for that age group, it's important that we pick those up. So that's why we remove those ages. The undetermined intent, we're a little bit, I'll put there strict, subjective. Most people would be looking at that and thinking, hold on, you can't have strict and subjective in the same bit. But because of our contact with people, and because people lead chaotic lives, whether it's through addiction, eating disorders, mental health conditions, medical conditions, again, it can be very, very difficult for the undetermined intent. So sometimes, to be quite frank, it's a bit of a gut feeling. Did this person intend to kill themselves, or is this an accidental overdose? Is this because of years and years of alcohol addiction? And again, I hope I'm sort of painting a picture of how difficult sometimes it can be to even sort of get to that first stage of really realising you're dealing with a suspected suicide. Third and final stage then, if we're still unsure, is that we'll look towards the Elphinstone criteria. And this was created for the railway industry by Professor Elphinstone. I believe it was in the 60s, I think it was. And this is what they use for the railways to determine whether or not something was a suicide. So, and this really is the final step for us. If it doesn't touch any of these things, then we don't classify it as a suspected suicide. Or if I'm reading through something, and, you know, over the years I've read through, I think just shy of about 2,500 cases of suicide, I kind of can see through a lot of things and understand maybe what is and what isn't, and I'll always justify that within the data. But certainly for officers on the ground who aren't trained in suicide per se, don't have that level of knowledge, we've put in this 3-stage criteria just so that they have something to fall back on, and they can go back and tick the boxes and go, well, is it or isn't it? Okay. I've popped the temps there at the bottom, which is probably about a 5-hour long webcast all on its own. So we don't record attempts. It's just there's too much volume, and even trying to classify an attempted suicide is inherently difficult. For me personally, when we talk about attempts, and it is something that we are trying to build upon, we have to have a grading system, everything from thinking about suicide to suicidal ideation, all the way up to, you know, a 5 or 6 stage grading system up to a life-saving intervention where someone is, you know, plucked off the side of a bridge or something along those lines. So we have to have that, because just classifying an attempt is even more difficult than classifying a suspected suicide, because what happens if somebody is just thinking about it? What happens, you know, what point does it become an attempt? Is it when they go and purchase the means to kill themselves? Is it when they think about it? Is it when they create the plan? Is it, you know, so all these different facets fall within the attempt sphere. Volume wise, we did a bit of a pilot a couple of years ago where we asked our call handlers to tag any call over a 3-month period that they felt was an attempted suicide, and in 3 months we had 10,000 calls that were tagged from that. And that was everything from, I'm worried about my daughter, son, who spoken about ending it all the way up to a member of the public intervening in someone trying to actively kill themselves. So, like I say, you need that grading and the resources, but that's why we'll steer away from attempts. I'm sure it probably would have been a question at the end. So why do people die by suicide within London? What do we see? We see all of this stuff here. You know, I'm sure many of you experience, and you've read your Durkheim and your Schneidman and all that kind of thing. And it's exactly the same what we see across the board, really. We get some really good information from suicide notes about motivations, and also from family members and what they're going through, and also through previous experiences with the police. So a lot of the people who we find have died by suicide have been in contact with us one way or another. We hold, you know, some good indicators as to previous behaviour and previous mental health illnesses, people who are in crisis and that kind of thing. That's something that I'll sort of build on a little bit later on in the presentation. So just some data then. So this data is from, all of these next few graphs are from 2017 and 2018 combined. So this formed part of my master's research, which I finished in October. If anyone's interested in it, and it was an analysis of about 900 suicides across London between 2017 and 2018 that the Met attended. If you go to Google Scholar and Google suicide outside home address, my dissertation and research is the top one that comes back. It's open access, so anyone can access it, and I did that on purpose because I wanted people to be able to access it and read it and have a look at it. And there's some quite good stuff in there, some quite groundbreaking stuff that's never been done before in London as well. It is written for the layperson as well. So if any of you sat there thinking, oh, I'm not really going to understand all this academic talk and things, the majority of it, because I'm not an academic by any stretch, there is written in plain language, and it goes into some pretty basic stuff, to be fair. So yeah, across London we find 3/4 male compared to female. That's standard. You know, most people will know that from national figures. Age bands tend to differ a little bit. I know the 40 to 50 population tends to be the high risk population. And bearing in mind, this is sort of 2 years combined. So this is the sort of stuff we were picking up as we started gathering the data for the first time. Was having a look at these age bands and seeing where do the rises lie, and where should we start putting our resources. Interestingly, though, when we broke down 2017 to 2018, see a huge drop in the 40 to 44 and the 45 to 49 age group, and a 50% increase in the 65 and overs age group. Don't know why that is. I suppose if anybody could answer that question, we'd have the magic panacea for suicide prevention. Could be that, if any of you remember, towards the end of 2017, there was the Calm statues on top of the ITV building, and an awful lot of sort of campaigning around that age group. You know, men, are you age 45? You know, please talk to each other and everything else. I think we saw TV adverts, didn't we, where they were in a pub and things like that. So could have been down to that effect. Could have just been because of the year. Could be that people moved out of that age group and into somewhere else, or people moved out of London at that point. There's so many different variables that can affect that. But this is the kind of thing now that within our role within the Met, we now can have this data and we can have a look at this and see what is actually going on and what is happening, and maybe tell if, you know, if we were to run a campaign for the over 65s, we would be able to hopefully see if that was working in the months and the year that sort of followed by looking at these sorts of figures. So ethnicity then, by far, is white people across London. The other populations tend to roughly reflect their population demographic. So I think people classified as black is about 8% of suicides during this period, but I think they account for about 10% of the population, so slightly underrepresented. The problem with this, and this is one of the problems with suicide prevention work in general, is the crude way in which we have to gather this data. We have absolutely no option other than to go by sight at the moment. So if the police officer turns up, they will classify you. These IC codes are what police officers use for a quick descriptive term. They were created for essentially for like foot chases, so that if you were running after someone, you could give a good description quickly over the radio by using these codes. So at the moment, we rely on what the officer's seeing when they turn up to a suspected suicide. I am working with the Home Office at the moment to try and be able to provide them with a list of people, and then they provide me with, are they born British? Did they seek asylum from another country? Are they naturalized here from Europe? Are they married in? You know, whatever it is. And again, that's not to criminalize people, you know, for immigration offences or anything like that, but it is to try and get into any at-risk populations that are happening. And I'll talk a bit more about at-risk populations in just a second. So this is really, really crude at the moment. If we have, say, white and black mixed, I always categorize them within the black category. But again, like I say, it's not perfect, and there's always that caveat with the data. We are trying to make it better, but it is something that, certainly suicide prevention wise, we need to find a way around this, because yeah, there's a whole host of different communities within these codes. You know, you think about Black African, Black Caribbean, Black British, you know, same with someone described as white could be from almost anywhere in the world, from Europe, from, you know, parts of North Africa, or even, like I said, the Caribbean or wherever. So it's not accurate enough for me personally to start relying on these figures for suicide prevention measures to be implemented. We need to get better at this, but that work is sort of being undertaken at the moment. So one of the findings of my research is that Eastern European population in London was overrepresented. So they accounted for about 10–11% of suicides between 2017 and 2018, but account for about 4% of the population. Now, this sort of started coming to my notice because as I was inputting the data onto my data sheet, we record the nationality. Now, the numbers for the Eastern European community are higher than this, but we have people who, again, to be crude, who have Eastern European looking names who are classified as British, and I have to go with what the officers classified them as for their nationality. So these numbers are higher. So when I first started noticing this spike, or not really the spike, but this trend, I then started to look through the academic research, and there was loads out there from Germany, France, Italy, Spain, Holland, Belgium, that basically as Eastern European communities came in to those countries, the suicide rates within those communities was higher than the suicide rate currently in the country. But we completely missed it because we'd never gathered this type of data before. So this is, again, another reason why I'm trying to get contact with the Home Office and trying to get the nationality of the person sort of nailed down, because I see other political changes happening in the world. You know, we think to Hong Kong, to, you know, what's gone on in Afghanistan, and in recent years, Rwanda, Somalia, places like that, places that have a higher suicide rate per population head than we do here in the UK. And now we suddenly get a big influx of this community. Do they bring with them their suicide figures as well, which you would expect that they would, plus with the added trauma of them having to be forced to, you know, seek asylum elsewhere or emigrate elsewhere and things like that. And probably for the first time as well, if we can get this nationality now down, we can actually answer the question of whether or not we would see an increased risk in people seeking asylum, people coming from war-torn countries, because I think most people who work in this environment would suspect, and I would say I would be one of those, that they would be at higher risk of mental health conditions and suicides in the future. But at the moment, we can't, certainly within London, we don't have that data in order to be able to do that. So with this community now, with the Eastern European community, we're taking on loads of work with the Met, we're meeting with community leaders, we're trying to get into them through community leaders and through churches and things like that, to try and, you know, go and talk to them, because there are some real significant differences, cultural differences. You know, I spoke to a Polish charity from Scotland who's doing loads of this work, and the lady there, she said to me, "Oh, Polish men will only talk to two people, their wives or their priest. You know, they don't go to the doctor for mental health problems, you know." So it's about trying to get into that culture wherever we can, and then using that as a template, so that when we do have these incoming migrant populations, especially into London, which we see quite a lot, we can put stuff in early to try and reduce that risk to them. So we now record as well sort of location type, and 2/3 happen within the home address. So within London, we account for roughly about 10% of all suicides that happen across England. So somewhere between 600 and 700 a year, depending. So within that, you have 400 within their home address, which means you have 200 actually that are outside the home address. That's potentially 200 deaths that members of the public are coming across, that people who are walking their dogs, or, you know, loved ones are finding out in the street or in different areas. Now, we started looking at location type because, me being naive at the beginning of my research 5 years ago, I was sat there thinking there's bound to be an area which is high risk, and then all we do is stick loads of police officers in there for a couple of months, problem solved, reduce suicide, dear medals, brilliant. It's absolutely not the case. Within London, unlike other areas of the country, we don't really have high risk locations other than home address. So it's a strange one actually, because almost all other counties across the country, you ask them, and they'll be able to name you their high-risk locations. Now, is that because of volume here? I just don't know, but it was also part of this research was to look at the effect of having a 24-hour public transport network on suicide. So are people facilitated by the fact that they can get anywhere across London at any time of the day? And in actual fact, as I'll show you in just a second, it doesn't appear to make a great deal of difference whatsoever. Because again, the plan was thinking, tier medals and reducing suicides. Brilliant. Well, when it comes to night buses and things like that, we'll train all the night bus drivers on suicide prevention and how to talk to people and how to spot the signs. And, we'll stop all these people. But in actual fact, most of our research is kind of showing that people don't jump on trains and tubes and buses to get to places. It happens quite rarely, in fact. So seasonal variations, and this is something I was talking to Barney about just before everyone came online. We do see seasonal variations. I think the academic literature sort of points towards a seasonal variation difference between men and women. So off the top of my head, I think that women have, or there's evidence that women have like a 2-year cycle. So you see like these waves, they're not the same year on year. So, I mean, the June one here is quite stark, isn't it? So June one year is one of the lowest. June the next year is up there as an increase. So women have this kind of wave that goes in 2-year cycles, and men seem to have this wave that comes in 3-year cycles. Effectively, we need more data to confirm that within London. And then COVID is going to have thrown a massive spanner in the works with that one as well. So it'd be interesting to see 3 years of data pre-COVID and then 3 years during COVID to see what this is. But what you can see here, I think, is a wave. So those bars don't look random to me. You get a few months where it goes down, you get a few months where it comes up, you get a few months where it goes down, and those times sort of differ. So you look at 2018, and that's probably the best example of that. So one of the things that is part of my job, and one of the things that I try and inform the NHS of, when we see these numbers start coming down, say for example, if we were back in 2018 and I was looking at data for June, July and August, I'd be saying to the NHS, right, numbers are coming down, which means at some point they're going to start going back up. So right now, I need you to throw tons of resources into what we can to try and, for want of a better phrase, and to steal a COVID term, to flatten that curve, to try and reduce those suicides, because we know as they're coming down, that's not the time to take your foot off the pedal. Yeah, brilliant, whatever we did in June is working. No, because they're going to start going back up again. That's inevitable, unfortunately, and that's how this works. So methods of death, I'll sort of skip through these quite quickly. So hanging for men and women has become the most popular. You'll see there we separate out overdose other and overdose by prescription. And I'll show you some of that stuff in a second on the mind map, just about why we've separated out those things. Yeah, and here we are. Sorry for the creep charts. I'm not very good at my graphics. So you can see, I think it's males at the top, females at the bottom. So hangings are by far the most utilised method. We also break it down by borough. So you won't be surprised to see that Croydon is up there, not for probably any other reason than Croydon is absolutely massive. So it's sort of expected with the population size. But again, one of the surprises, you've got Camden there, one of the smallest London boroughs, but perhaps one of the most population dense boroughs in London. And also, having worked in Camden for a number of years, probably one of the sort of inner London boroughs where you'd expect a higher percentage of drug use, alcohol abuse, mental health conditions, social housing for the people suffering from mental health conditions, that kind of thing. So it's important, again, that we can have a look at these boroughs, but as I'll explain a little bit later on, in some of the problems with this is that you can have somebody being treated by South London and Maudsley NHS Trust, for example, who is housed in Barnet. And that can be very difficult then to try and say to Barnet, hold on, you've had this many suicides within your borough, but if Some of those are effectively people being housed and treated by another London borough, another NHS trust, and those things. It can be very difficult sometimes to try and work out what can be done. That's what I wanted to cover there. Right. So this was distance travelled from the home address. So this was the first time that anybody had looked at how far somebody had travelled from their home address within London to die by suicide. So everything on this data is people who have been found dead from suspected suicide. And as you can see there, the vast majority of people we find have travelled less than a mile from their home address. And this was one of the findings of my research, and it's now part of the guidance that we're giving to frontline police officers. If you have a high-risk missing person, forget ringing the hospitals, get the family to do that. They want a job, they can go and do that, okay? They want to help, they want to do something. Have a look on a map at their home address, draw a circle a mile around, and look for any parts within that mile, and that is where you're likely to find people. So, and the findings here, you know, speak for themselves. They're quite stark. Here it is in 2018 again, exactly the same, and it's exactly the same for males and females. So, you know, with those findings, that is really, really clear to me. But this also falls within other suicide prevention research, in that we know if you can delay somebody by, for example, 40 minutes, I think their risk of dying by suicide drops by 93% or something. So you think, well, how long would it take you to cover more than 2 miles? Well, you're talking 40 minutes, aren't you? I think the average person walks about 3 miles an hour. So again, are we finding people within that mile? Because that is the time when their suicidal ideation is at the highest. And in actual fact, as they travel further and further away, the time that it takes them to travel those distances, it then becomes, that's enough of a delay that it prevents some of those suicides. This would also fit in with some of the research they've done in other areas where they've, for example, moved car parks where people access high-risk locations, and they move them, firstly, so there's more chance of an intervention between the car park and wherever people are going, but also to delay them by this time. So for me, this is just the beginning of this type of research. It was, again, I was expecting lots of tube travel, lots of bus travel, that kind of thing. Almost all of it was on foot. We did have to take out some outliers. I think, and again, for those of you who are into your statistic, I think the mean average was something like 130 miles, because we had some people who had travelled over from the US, not specifically to come here to die, but you know, those are outliers that then just skew that level of data. But when we looked at it in this regard, I think the results speak for themselves, actually. And this is, again, something that evidence-led practice that I can sell to police officers to say, look, go out and have a look and see if you can find them there. That's our best chance of finding people. So yeah, back to our role within the suicide prevention. So we attend, as the Met, between 90 and 95% of all suspected suicides within Greater London. Like I say, roughly that equates to about 600-ish a year. We have a data system, which is Northern Europe's largest system. There are rumours it's the biggest one in the world, but we're not allowed to say that because we don't know for sure. And it encompasses every local authority, every NHS trust, every mental health trust, every STP, a number of charities, 3 police forces, the RNLI, Her Majesty's Coast Guard. I think that's it. And all of those include information sharing agreements and everything else that goes with it. So you can imagine the system itself is massive. It took 3 years to implement it, and I was happy to be part of it from day one, right the way through till its current form. Now, when we put details onto the data system, this includes referrals for bereavement support. So the whole of London, first place, my understanding, in the country to be completely covered by NHS commissioned bespoke bereavement support services for next of kin and for witnesses who come across someone who's died by suicide. So the unofficial service level agreement is that I will update the details within 72 hours of the suicide being recorded on Met systems. It's normally, in actual fact, within 24 hours, and then the bereavement support people will contact the family, the next of kin, the witnesses within 72 hours of that going on. So, you know, it's a really, really fantastic system. And I think the report I saw, I think it was last week, they're in the 90s percentage-wise of actually contacting people next of kin and bereaved family and getting them some help and things like that. And they're now looking at, can they have older data so they can contact people who may have been bereaved last year, the year before, and the year before that. So the data system does help us, I say helps us to spot sort of contagions and trends. It's created a bit of learning. One of the things that so this system has been in place now for nearly 18 months. One of the things I would say my biggest learning curve with it is that people in London aren't just connected by geography. In actual fact, geography is probably the least connecting factor. That's a sentence. People connected by online forums, by schools, social clubs, sports teams. You know, we have children within London who jump on a train at Stratford and go down to Gravesend to go to school. So if something happens within that school, we don't necessarily hear about it in London. So when I've put there, it helps us to spot contagions and trends. In actual fact, what it's done is it's shown us that what traditionally has been thought of as high-risk locations, as trends in geographical data, in actual fact, we need to start digging a lot deeper. We need to start looking at how these people are connected. I know I picked up a case last year where it was two people, identical circumstances, so identical that I thought, because what sometimes happens is the police officer who's doing the report gets kicked out of the reporting system, so their mate does it. These two cases were so identical, I thought that's what happened. And in actual fact, they're in two completely different areas of London. And it was only because I read through every single one that I was able to link them. And then eventually we found out that they were linked through a social club. So, you know, that has really shone a light on that work around, we need to get away from this traditional geographical look. That's what I'm sort of labouring that point now. Sorry. We can also offer an investigative capability for safeguarding concerns, but not only for safeguarding, it's something that I'll maybe come into a bit more detail. So we have methods where maybe the means have been obtained illegally. For example, you know, companies who supply certain products must legally take on board checks and things. And if those checks and balances haven't been done, we're now in a position where we can look at it and I'm starting to ask the question, well, can I go and prosecute that company? Now, I'm in no way trying to criminalise someone's freedom of speech, someone's choices, or trying to, you know, recriminalise, if you like, suicide. That's absolutely not my bag. But if to get companies and people to stop supplying certain things to people, or to make them more aware of the potential ramifications for products that they supply or information they give out, things like that, if that is a threat of prosecution, that is a road that I will happily go down. And I think that's a really important one for the police, in that we've got to remember we are the police, we can offer that. And whilst I'm all up for being soft and passive measures and everything else that comes with that, at the same time as well, we have to have that enforcement ability, I think, to do that. It just has to be managed really, really carefully. And we've got a few different cases, not at prosecution level yet, but you know, we're talking actively with partners, with Mayor's Office, with NHS leads, with public health leads, with academics, to say, right, you know, what point do we go enough is enough? And we have to maybe send a bit of a ripple through this industry by saying, okay, we'll prosecute you. You know, if you're going to be negligent in what you supply and the information that you give. But that's probably, again, a topic for another day. So I've put up a little bit of a kind of a process map, just so you can see really what my work involves as the police. And the actual one has about 15 layers. So I'll cut it off at 4 or 5, just because I wanted everyone to be able to read it. I don't want to blow your brains. So at the top there, you've got the hub on the top left, and that's the data that informs most things. Underneath, I've put about our own internal reporting standards and increasing the standards of this, and that's some work I'll go into in a minute. We have our safeguarding strand straight away, so I'll meet with safeguarding adult boards, with children and young adults, safeguarding reviews, with CQC sometimes around different cases, as well as getting in contact with coroner's officers and things like that. So that is, I suppose, the primary concern, and that is also not only for people who have died, but the people they've left behind. So if they've got young children who are going to need specific bereavement support and things like this, and can we learn the lessons of how this death has occurred and everything comes with that. So there's a whole safeguarding umbrella piece of work that comes with this. As you move down then, so I always look at suicide prevention as having really 3 big stages: access to good data, good reliable data, which we have; access to good bereavement support for the next of kin, and sort of early intervention. Well, the early intervention stuff, that's not the police's role in this. That's NHS teams, that's your mental health teams, that's all the other work that goes on around the training of being suicide aware and things like that. But reducing access to means now, to me, is something that certainly for the next year I will be focusing a lot of my efforts on, because I think it's a real big area that we can make a good difference in suicide rates. So again, that's through identifying trends, like I said, high risk populations such as the Eastern European population, and then the incoming threats that are possibly going to land, and what can we do to support those people. Just when you look at the Eastern European population as a good example, poor access to healthcare, poor access to language, tend to be manual workers, tend to be male, tend to be 40 to 50 years old, overrepresented in alcohol addiction. I'm not trying to cast aspersions on every single person from that community, but they tick almost every high risk contributory factor, and if we have other communities coming in, we've got to be aware of that and get onto that. I've said it there and sort of mentioned it earlier, are people linked by geography, by the method of death, or by online? And the online stuff is becoming an increasing area of my work. I'm increasingly finding myself looking how people have linked up online through various places. It's a whole, I know there's some work going on, and we've got the online harms bill that's coming in, but that will become, I'll put my hat out now and say, in the next 5 years, that will become the biggest area for suicide prevention research, will be online harms, people accessing information, people accessing means, and that kind of thing will become huge. And I don't want to catastrophize or anything like that, but it's just something I think the suicide prevention community, as we all work together, we need to have one eye on that, and we need to start looking forward a little bit rather than being reactive. So also when we're talking about reducing access to means, site visits. So we're now asking our multi-agency suicide prevention groups, when there's a suicide that's happened outside someone's home address, can you go and visit the site to ensure are there any measures that can stop somebody else accessing that area? We're meeting with some pharmacists and running some research with, hopefully with the University of Huddersfield around safer prescribing and looking at ways that we can do that to reduce overdoses by prescription medication. And I know that's a very, very complex area with actually very little research, but again, because we have the data and we can, within London, we're fortunate that we have such a volume of everything that we can put into measures and really see the effects pretty quickly. Reducing access to means, I also need to build some intelligence gathering pathways. I'm sure if any of you are physicians and treat people with mental health conditions or treat people who are actively suicidal, the amount of intelligence that you gather on a daily basis is far and above what I ever hear about. And there's a real ethical discussion to be had here where we've got to have it out in the open, and we've got to say, at what point do we not share specific details of the client, but at what point do we start sharing specific intelligence backwards and forwards by saying, we've heard they're doing this. Is there a way that you can stop it at the end source? You know, I'll deal with the person, you can deal with the end source. And we've got to have an open and frank discussion around that. I sort of mentioned the prison service and probation. So when we look at trends and contagions, we ran some research on people who were released on bail. We found that the majority of people who are released on bail, released under investigation, died by suicide within 48 hours of a police contact. When you look through the research, it's exactly the same. I'll say exactly the same. It sort of runs in parallel with people who are released from mental health institutes who've been detained there, and people who are released from prison, and people who are on probation. So again, I sort of contacted prison service and probation office and said to them, right, so what's your best practice? What's our best practice? How do we help each other out with this? How do we line up those two behaviours? You know, this is their world we're stepping into. What is best practice, and how can we change how we're dealing with people to try and keep them safe? And bereavement support, like I say, that's pretty much already covered across most of London. We're aiming for 100% record of offering support. One of the things that I would like to see, and I think it's sort of covered on the next slide, is I would like to see a change in legislation whereby people who are identified as being bereaved or have witnessed a suicide are automatically referred into NHS commissioned bereavement services. At the moment, we rely on consent for that referral, but I would like to see a change in legislation to say you will automatically be referred in and you can opt out if you choose to. I absolutely think that is the way to go. We have the system in place to do it. Are we the best people to try and run that campaign? Probably not, because as soon as the police ask for anything, the danger of being a police officer is that, hold on, why do they want this? Why do they want your data? What is their end goal? There's always a suspicion that we have something a bit more untoward, going on, when in actual fact it's not. It would be, completely confidential and everything else. So maybe look towards some of the community groups who can help me out with that as a campaign in the near future if they agree. But that auto referral legislation, I think, would change suicide prevention for the better. So some of the difficulties then in suicide prevention and the police. So my role has only been full-time since October last year. Prior to that, like I say, I was searching it for 5 years. I was in the back of a police car, going to calls on blue lights, gathering data, sitting in meetings, saying I'm really sorry for the sound of sirens, and then jumping out and having to deal with some high-end incident sort of thing. So I've had to put in a lot of work, and I'm gradually joining the dots and getting everyone in line and everything else that I needed to. But it is taking some time. I need to change the reporting standards and the culture at the scene of a suspected suicide. I'm not saying it's disrespectful in any kind of shape or form, but a police officer at the moment turns up to a sudden death and they go, is this a murder, yes or no? If it is, they literally shut up the scene, call down CID and everything else. If it's not, the reporting standards are barely minimal. They very rarely answer the question, why did this person choose to take their own life? And that is something that over the next month or two should be publishing some reporting standards for them to improve that. So again, we can improve the data, and then we can improve suicide prevention measures. Where to focus efforts? Yeah, so there's only me within the Met that does this full time. While I often get offers for help, people are really busy, and it can be really difficult to throw someone in when they don't have a level of expertise and things, because ultimately everything comes with data sharing agreements and everything like that. So where do we focus our efforts? There's so much going on across London that sometimes you can get a little bit overwhelmed, and sometimes you just have to stop and pause and go, right, what is a priority and what isn't? Suicide prevention has never been seen as primarily a police issue or priority. You ask any police officer, why did they join the job? None of them will tell you is to investigate suspected suicides. You know, it's catch robbers, catch burglars, and that whole ethos is bred into you through training school and everything else. I completely understand why. So we are creating a bit more waves. It is getting a bit more political weight as well. A few more high-profile people are interested. I know the Mayor of London is really interested in suicide prevention and suicide prevention schemes and things like that. So it is gaining a foothold. But again, resources, like I said before, it's just me across the Met that does this. And you know, I had a week off work and then came back to a week of Extinction Rebellion policing. So I was effectively out of the game for 2 weeks, and then you've got to try and play catch up and everything else. So one of my pet hates: the borders of the Met Police do not match local authorities, which do not match NHS areas. I don't know if there is a way to hit the reset button here, but can we just line everyone up? It would make everything so much easier. So that you can just go to a meeting and you know that police officers aren't necessarily crossing borders between local authorities and NHS areas. It can be so confusing. And like I said earlier, you can have somebody being treated by one NHS area, living in another NHS area, who dies in a completely different NHS area. And it can be difficult at times trying to juggle all those, and people are trying to do their own thing and everything else. So I think within suicide prevention, and we work with Thrive London and the Mayor's office, we have quite a good overview of what's going on across London, but we need a little bit of a uniform sort of response across London to sort of try and focus all of our efforts in one direction, really. And at the bottom there, there is some legislation that needs changing, and it's very difficult to write legislation to cover everything, you know, when you're looking at a specific problem. The first one I would like to see, like I said, is changes to data protection law to say we can do an automatic referral for people who are bereaved by suicide, and they can opt out and they have that. The others, again, there's some online harm crimes bill. If any of you read through the draft of that, that's coming out, I think it's November time. But as inherently, whenever we create new laws, the internet and other areas just find ways around it. And it's really, really difficult. And like I said, we have to be really careful about demanding more and more laws while we're trying to maintain people's freedom to speech and rights and everything else that go with that. So what's coming up? Things to look forward to in the future. So witness support resources launch. So we've been working on this for a few months now with the Support After Suicide Partnership, Samaritans, Grassroots charity down in Brighton, Sussex Police, and effectively what they've done is they've created this whole publication around what happens to someone, you know, where's the resources for if somebody witnesses a suicide of someone they don't know, you know, like your dog walk and things like that. This resource is planned in the near future to be sent to every single witness who is identified at the scene of a suicide. So that, I think it might launch tomorrow. So please keep your eye on the Met's Twitter feed and on the Samaritans Twitter feed and Support After Suicide Partnership, because I'm fairly certain it launches tomorrow or Thursday. And that's a really, really fantastic resource, actually. And if anyone in this group who's listening now was involved in that, thank you, because it's brilliant, especially if you were the people with lived experience who contributed to that, because it's a fantastic resource. So the Met, should we call it a policy freeze? Technically not a policy. We call them standard operating procedures in the Met. It used to be called a strategy. It literally changes every month. It's been out to consultation. It's now been finalised. It's sat with the legal team. It should be published in October 2021. And then once we've got that, we can then put out the investigation standards guidance. So our SOP is the baseline for what we're going to do as the Met. There's nothing specific in there, but it allows us to build on it. So it says, you know, officers attending should follow the investigation standards guidance and things like that. And then we can go into more detail under the investigation standards guidance and build on that. Changes to the hub, to the data system, to enable identification of trends in high-risk locations. So, like I say, we're trying to, because the geographical link maybe isn't always there anymore. we're trying to find other ways to identify if there's a trend. So, for example, can we input, for example, if you know somebody went to a certain social club, or if they went to a certain school or university, if I then put in that university or that school a second time over, I don't know, 5 years, it will automatically flag up the previous case. And that's the kind of thing now that we're looking at to say, hold on, we can start spotting these things. And the people who operate the data system have been fantastic in enabling us to kind of throw ideas at them and have a really good can-do attitude. I start next week a PhD at Middlesex University, where I will be looking at a 3 to 5 year analysis of the data systems from around the UK and the world. Believe it or not, there's no real guidance around setting up a data system for suicide prevention about what data do we gather and why. So that it's going to begin with interviews and things in November, and I'm lucky that I have access to all of the police forces in the UK and some high-profile people from around the world who have these data systems, and hopefully by the end of this period, when we have the analysis, because of course I'll be involved in changing our own one, we'll have the gold standard system. If not, yeah, we'll be in a bit of trouble if I'm responsible for that research and I don't manage to get us the gold standard system. And lastly, joining all the dots within Greater London. There's so much good work going on, but you know, I try and join the dots with the Home Office, and then have to join the dots with veteran support for people who are ex-military, and asylum services and immigration services, and the DWP. So all of this stuff is ongoing, but we're getting really, really close to a place where, for London, in my view, you've got some really good suicide prevention work going on there. No, so because it depends on what ward you want. You know, and again, if you're talking about policing areas or local authority areas, sometimes they're a little bit different. So effectively we don't, I'm afraid, and there is the danger there as well that if you break them down too much, you start relying on really small sample sizes, and you know that can really skew your data sometimes.